Welcome to this video, and an amazing team this morning. We've got Professors Robert Clancy and Angus Dalgleish, who are both currently in Australia. Gentlemen, thank you for coming. You're most welcome.
Good to be here.
And me.
Now, the background of these gentlemen is well known, but both are very senior physicians, consultant physicians, professors of medicine, very long research history. Professor Dalgleish is currently an oncologist, although he's done many different things throughout his life, including being a flying doctor in Australia, I believe.
Yes, I'm back here now, though, but not flying.
For a period of time. And Professor Clancy, of course, is an immunologist. I'd like to start really with a bit of background, if we could, on T cells. Now, these are T lymphocytes. They're a type of white blood cell. Maybe just, Professor Clancy, if you just start us off briefly on what a T cell is, and then maybe Professor Dalgleish on why this is so important, the act that we want to encourage T cell activity and take away things that suppress T cell activity. Professor Clancy.
Okay, well, if you go way back in time, 100 years ago in immunology, we knew about antibodies. We knew there was something in the serum or the plasma of blood. And we also knew that sometimes cells in the blood mediated a different type of immune protection. And basically in the 50s, 60s, it was recognized that a particular type of cell, which was a pretty boring looking cell, it was just round with a big lump of nucleus in the middle, was called a B cell. And there are probably a lot of reasons why it was called a B cell, but theoretically in textbooks, it was because it made antibody. And then an Australian called Jacques Miller, who was working in England, found that if you took the thymus out of little baby mice, they were unable to mediate this cell type of immunity. So remember, we've got two types of immunity, an antibody immunity and a cell immunity, both aimed at resolving infections, getting rid of cancer cells or things that were foreign. And the cells that were derived from the thymus gland of these baby mice, with great imagination, immunologists called T cells, T for thymus. And so we had B cells and T cells. Now, that was in 1963. I remember it well because I had taken a year off from medicine as a medical student to work on, shamefully, messenger RNA. And, sorry about that. And then the T cell progressively became an enigma initially because they couldn't work out what the receptor was, how it bound to its antigen, and then a whole lot of new things were found, like antigen presenting cells, the way in which the T cell got activated. And then they realized that not only could T cells kill cancer cells or certain infected cells by virus or even bacteria, but also they could do a lot of other things, including regulate, make the B cell make more antibody. Some of them made B cells make less antibody. And so we had regulation T cells, and the whole thing got completely out of hand. And so here we are today, looking at T cells and B cells, but in all sorts of divisions. Angus will tell you why T cells are really important for people with cancer, because they're so important in killing the cancer cells, and I'm really fascinated to hear what Angus has to say about that. I'm interested in T cells because, surprisingly, they're the ones that mediate protection against airway infections, from bacteria to virus to COVID to flu virus, whatever. It's the T cell. So while I'm trying to get the T cells in to make them work, Angus is keen to get the T cells that are there to work better. So I'll keep quiet now, and Angus can take the story from there.
Yes, I think on the T cells that when we discovered how important it was for HIV, the fact that HIV could enter one of the subsets of T cells called helper lymphocytes through the CD4 as the receptor, which I was very lucky to be in a position to be one of the first to describe. And we thought that that was it. It went into these cells and killed them. And in trying to understand this, we came up with the overall picture that actually the T cells are the conductor of the immunological orchestra, because they talk to the B cells, say, we need more antibody here, chaps, you know, and a specific one. They give the messages. They have the memory. And often, and certainly with the COVID vaccines, we had this terrible alarm. Oh, the antibody response wanes, dies down after the vaccines. We must boost it up. I mean, nothing could show that the people who said this knew nothing about immunology, because that's what happens. And the reason it happens is you should have programmed the T cell so it's completely programmed, so the minute it sees the agent again, it sends a message to the B cells, which are just sitting there sleeping. The message comes and immediately it goes up. Whereas in a primary infection, it would take several days before it can start to mount the infection. So that's why T cells are very important. They remember and they control the immunological orchestra. But it was very simple in the early days, which you've done the history of very well. B cells and T cells, and then T cells were regarded as difficult to understand. So like everything, they're split into two sorts. The helper T cells with the memory and everything, as I mentioned, and then the CD8 that do the killing. And once again, the CD4 talks to the CD8, or the way it evolves, so it knows what it's going to kill. And this is all part of what we call the adaptive immune response, because it's dealing in seeing specific things, making specific antibody. Now, my interest in T cells has got much more basic, because I'm very interested in the fact T cells have a role very early on, long before they have a chance to take photographs of the incoming antigen and work out what it is and what needs to be done. There's much more basic T cells, and we call those natural killer cells and gamma delta cells. I mean, gamma delta refers purely to the receptors. On the ordinary T cells, they're called alpha beta. So they just said these cells are different, they don't have the same receptors, but they arise earlier. They are terribly important. They're part of the frontline battalion, the first line. Anything that is not normal, they will start shooting down, as it were. And my own group has done a lot of work on these gamma T cells because we think that they're the most important ones in controlling cancer. And a big overview in Nature Medicine by a chap called Gentile showed to everybody's amazement, they had examined lots of data on tumours and responses and showed the gamma delta T cells were the most important. Now, I love this work because it confirms my impression that in dealing with both incoming invaders, viruses, etc., and the T cells, this is much more frontline. So it's what I call, it's non-specific, whereas it does the fighting before the more sophisticated T cells have a chance to take the photographs, program the computers, and tell the B cells exactly what antibodies are required to chuck out to neutralize whatever this is. And then with regards to what I said with cancer, it would appear that these frontline T cells, I believe, are actually far more important than the antibodies, the specificities for cancer. But that's speculative for discussion.
So I used to call these natural killer cells. Is that correct? The larger lymphocytes.
Yes, I mean the what I call the innate immune response. So that means it's innate. It doesn't need lots of instructions. Includes the natural killer and the gamma delta T cells. They're very similar, except they use slightly different receptors. And the natural killer is probably the most primitive of the lot. And then you have your adaptive T cell we've been talking about. The gamma deltas are somewhere in between, with a more primitive receptor recognition, part of an evolutionary process, perhaps. But it's interesting that they seem to be more important than the CD8 cells in a lot of experiments. But in those cancers where the CD8, which is heavily formed and programmed against cancer antigens, they are part of that evolutionary process, so the body can see it.
Gus, so when we look at modern chemotherapy, immune therapy for cancer, when you're neutralizing the blockers, the CD1s or the CTL4s, are they operating on your T cells or the CD8 T cells?
When you're talking about the antibodies,
The antibodies you use to treat people with cancer.
Target the checkpoint inhibitors like PD-L1,
Yeah,
etc.
PD-L1, yeah.
And CTLA4, which is the first one, ipilimumab. What you're doing by that is basically taking the brakes off that response. They're there, but they're sleeping. So when you bind this, you're removing the negative feedback, so the T cells produce whatever
These are CD8 T cells.
They're CD8 T cells and there's other T cells, because they can also produce antibody responses.
Right.
But you're just removing the brakes. And the important point here is that although they've been fantastic, still with any one of these drugs, less than half the people respond, because the other half haven't had the priming that allows a good response, or it's been inhibited by yet something else. Yes, so it's an antibody we give, and I just really want to make clear that this sounds like a paradox. You're giving an antibody for cancer, so people say, "Oh, antibody is very important for cancer," but actually it's indirect. The antibody is blocking the brakes, so the T cells can fly off and work because they're being suppressed. It's like they're being released from a cage. It's rather like the checkpoint inhibitors are unlocking the cage, allowing all the T cells to fly out. And that's why they can be very good for treating cancers, but they come with tremendous side effects because they're very non-specific. And that's why you get a lot of autoimmune disease with them as well.
So let me see if I've got this right. So normally the T cells would quite like to beat up the cancer, to destroy the cancer cells, but they're inhibited from doing that because they have natural inhibitors that prevent, in the natural circumstance, autoimmune disease. But because this patient's got cancer, you've decided it's appropriate to block that. So you give antibodies that block the inhibitors of those T cells and leave the T cells to become really quite aggressive, tough guys that go around eradicating the cancer.
And this is absolutely indeed right, but it actually also highlights something that's terribly important, and that is that cancer has been part of a great programming network to suppress the immune response, to stop those T cells attacking it. Because in the very early days of cancer, at odd mutation, the T cell comes along, sniffs it, takes it out. And then randomly, you might get this occur in an area that's what we call immunologically immune defensive. There's a lot of shields around it, so the T cell can't get in it. And if you get the next mutation, the tumor can start going. The first thing it learns, once it becomes completely independent of the growth regulatory factors, it starts putting out factors that encourage suppression of the very immune response, which, when you think about it, it has to do, because cancer is terribly susceptible to the immune response, to the point where other people have suggested, doing mathematical genetics, etc., that we get cancers arise every single day of our lives, and they're controlled by the T cells. And it is only when T cells are really suppressed that these cancers suddenly pop out, particularly if they're driven by viruses, and viruses are controlled by the T. And of course, the greatest example of that was when HIV came along. HIV completely interfered with T cell control. It literally killed the conductor of the immunological orchestra. And so the next thing you know, that the viruses that cause cancer sitting there, like EBV, or human papilloma virus, hey, we've got no one controlling us. Hey, let's go. And so it was these tumours that popped up in HIV patients first. So the EBV causes the lymphomas, and then we found out that the HPV caused cancers in these patients. And these cancers were first, long before the others. But as time has gone on, more of the classical cancers became involved.
You've got to admire cancer in a way, really, haven't you? I mean, it's a bit like an alien invasion movie. I mean, it's horrible, but you've got this sort of mutated phenotype of cells that not only multiplies and makes sure it has its own propagation, its own regeneration. It is so clever it can inhibit these absolutely brilliant immunological mechanisms of human and animal physiology. It's just quite incredible.
But the other side of that story, John, if you look at biology in general, if you look at parasites, for example, the good parasite, the successful parasite is one that doesn't kill its host.
Yes.
And what you're finding in cancer is the cancer cells are unbelievably clever, with an incredibly sophisticated network of positive and negatives, and it controls it, but it kills its host. So it's biologically stupid, but it's logically and genetically incredibly clever.
Yeah. I mean, basically what...
We have these sort of people administering medicine these days.
I was just going to say, the analogies just flood the mind, Robert. Just names come to mind. But we'll pass on that one. Gus, you were going to say something.
Yes, I was going to talk about where you were talking about the parasite. I mean, that's what cancer is. It becomes a parasite. It's very clever. It's dynamic evolution. It's evolving within the body the way any other bug would be, to see if it can outcompete. Survival of the fittest. That's what it is. But with cancer, it can be survival of the fittest to the point where it kills its own survival.
Yeah.
Whereas the other bugs and things can grow, and you live with them, and it is a real, what they call symbiosis. There's a lot of evidence of symbiosis. And as people get older, and certainly as we've found out as you get older, a lot of people with all the sophisticated analysis we have these days do, as they get older, when it's discovered they have odd aches and pains, they get a blood test done, and they find, hey, they've got leukemia, or the lymph node's actually a lymphoma. How long have you had it? Oh, months, probably 2 or 3 years. Caused any trouble? No, because it's evolved from the second stage, as it were, but the immune system's really capable of treating it. So you don't know it's there until you come to a period where you've got sudden suppression of your T-cell response, which there's many things, as we discussed before, can do that.
Yeah, you take prostate cancer, where probably 90% of people in their 90s having if you look at their tissue after they're dead, they'll have low-grade prostate cancer, and it's probably been there for 20 or 30 years.
Absolutely true. In fact, in the Vietnam War, there was reports that even the young people, in their 30s, 40s, that many of them at autopsy had very early prostate cancer. So it may well be, it may take decades to evolve before it's actually causing any problem. It's being controlled. And it's one of the cancers that I believe is affected by your overall healthy immune status. And we certainly know that vitamin D and anti-inflammatories play a big role in the control of prostate cancer.
That's interesting.
Yeah, it's quite amazing, really. I mean, I've seen patients in theatre, for example, and the tumours are like just all over the place, just masses of them. And yet, if the T cells were activated against that, is the immune system still capable, theoretically, of eradicating tumours that are all over the body, if they were sufficiently activated against the cancer cells?
Yes, providing those tumours are quite small volume. There becomes a time when the tumour is just too big for the T cells to infiltrate. I've certainly seen multiple small volume Mets completely disappear with good immunotherapy.
Yeah.
But it's a very tall order if you're dealing with tumours that are 6, 8, 10 centimetres or so. If it's just the one and there's lots of small ones, then removing the big one and going for the smaller ones is actually a reasonable strategy with immunotherapy.
Right. So basically, I think I'd like to have more active T cells. I mean, I'm well into my 60s now. What will my T cell activity be like now? Will it be as good as it was when I was 25?
No way. It's actually...
Oh.
The age, I think, was 65. 65, you drop over.
What do we do about this? Is there any practical approaches we can take to increase our T cell activity? Now, I know you've both got answers to this question, so who'd like to start?
Robert.
Well, I was just going to have a parallel comment to Gus's on cancer, because I'm interested in the environment, not so much of the cancer cell, but in the airways where, say, a COVID virus infects. And there's remarkable similarity. It's always surprised me, the similarity between the challenge of a T cell trying to get good responses against the virus there, as it is in the cancer environment to get the T cell to act on the cancer cells. And it's interesting listening to Gus talk about the non-specific components of protection, immune protection. It's exactly the same. You put in a specific cell, but it's so quickly suppressed, it's got to very quickly teach the innate immunity to actually continue the action. It's given a term now, it's called learned innate immunity.
Yes.
And in fact, you change the nature of the white cells and the various cytokines so they become self-perpetuating. And every now and again you have to give them a burst of good T cells to get it going. So you go from specific T cells that you're putting into that environment, stimulating a non-specific outcome, which means that it's going to protect not just against the COVID, but the flu in a non-specific way. And I love, biology's very good at getting to grassroots principles, isn't it?
It is. There is a very interesting similarity here, and that is with the virus going into the airways and infecting the airways. What happens, if the first line defense innate immunity, or your memory, because you've seen it before, wins and it all settles down and you just have a little cough and you get better in a few days, that's fine. But the thing that causes us all concern, and especially respiratory people in hospital, is when the condition is really bad. And that means that even if you've got an immune system, you can't do anything about it because it's caused inflammation. And this is very relevant for COVID. It's caused a dreadful inflammation, which was completely ignored and misunderstood by the people in the front line because they ordered ventilators for the people with this respiratory difficulty in breathing. They might as well have organised AK-47s for them because it actually killed them. I mean, the ventilators was the biggest cause of death because it pushed the results of the inflammation back into the lungs, causing completely blockade so they couldn't breathe. I mean, it was like throttling them. And they thought, the people who ordered the ventilators, that it was because the virus caused leakage and that you wanted to push the fluid back in. So we were dealing with something more like cystic fibrosis and inflammation. Now here's the important bit. When you've got this inflammatory environment, the T cells can't get through. They just bounce off. It's a complete waste of time. So the only thing that made a difference in that time is to give them steroids, dexamethasone, time-honoured way of treatment. Again, the people who handled all this, and I want them brought to bear account for their incredible stupidity for this, they organised a trial called Recovery with 6 arms, one of which was dexamethasone. By doing that, 5 of the arms were denied dexamethasone, which as the trial went to great efforts to show that dexamethasone was the only one that was any use. Well, we all knew that. I mean, anybody with half a brain who's ever been in intensive care knows if you've got chest inflammation, you give them steroids, it settles it down, and then the immune system can work. because it can actually see its targets.
Yeah, completely unethical doing clinical trials for things that we know exist, because you have to have a placebo group who don't get the treatment.
Yeah, I would like
And
to have a word with the people who approved that trial, because I think that it shows medical negligence on a grand scale.
yeah, it really is quite incredible. What about practical ways of stimulating the T cell response? I know you both believe in what's called bacterial stimulation. If you could just sort of briefly tell me your two approaches, do your approaches agree? Maybe Professor Dalgleish first. What's your approach?
Well, I was going to say Robert
No,
first.
no,
but
I think
I don't want to cause any fights.
no. Well, it is very clear, and you know, it must be appreciated that this comes after decades of research and a sudden realization. And it was my interaction with Stanford and Rook, you know, John Stanford, sadly no longer with us, and Graham Rook, who for years were looking to improve TB vaccines to get a better BCG. And they realized that in the presence of certain mycobacteria, not BCG, the outcome was much better. And they did fantastic research, but I don't think they've had enough credit for it. And they found Mycobacterium vaccae was very useful. But here was the real work. I mean, here was the real business. They found that they could make it much better than BCG by heat killing it. This, I believe, is serendipitous, because the same has been found with listeria, which has been used as a stimulant. And by accident, that somebody gave a heat killed and found it was much better. Well, it's the same with the Mycobacterium vaccae, and it's the way it's prepared. If you don't use the right buffer and the right pH, then it's not nearly as good as stimulant. So this is very important. But when you stand back, this agent boosts, first of all, the NK cells and the gamma deltas. We spent the last few years in my group showing it's the best stimulator of gamma deltas. It's much better than the standard ones. And so this is one of the reasons I believe it has been so useful in our cancer trial, and it would have been very important to have used that and not the messenger RNA vaccines as the immune boosters for COVID. And I make no apologies for saying that, because I said it right at the beginning, and I was widely ignored on it. Now, why is it so good? It's because Stanford and Rook, when they pushed this, people saw that what they were describing, it was pushing the immune response that would have been programmed when you were young, and it just had sort of died down, or it wasn't there properly enough. And it got labelled in one big review, which actually went on to a big TV programme, and they called it the dirt vaccine. And I think that was a brilliant concept, because the dirtier environment, the better you program your immune system. If you live in a clean, sterile environment, you never get that good immune response. And if I may quote a wonderful, unexpected result from Copenhagen, from the State Research Institute, who've been working on BCG in Africa for years, they found after 50, 60 years of monitoring all these trials, that the kids that had BCG, as opposed to those that didn't in Africa, which would have been, and they would have been exposed to many other dirty things, that later in life they had a lower cardiovascular and cancer incidence. So it really was a stimulant. That one study, I mean, I speculate all this, and a lot of it's right, some of it might be wrong. That study proved that stimulating with this dirt in early life actually had an improvement on non-specific, indirect agents such as cardiovascular disease, etc. And it makes sense. Just to highlight it, with regards to dirty bugs, it has been known for years that people in dirty environments don't get a lot of sophisticated conditions like Hodgkin's disease or multiple sclerosis later in life. And when you go into detailed analysis of people who've had several children, only the firstborn is likely to get these conditions, because the firstborn will have the cleanest environment. And by the time you have your second, give up on that, they just go, you've got too many kids running out, crawling around in the dirt, and eating mud and stuff. And they are giving themselves a much better immune system than the mollycoddled firstborn. And all the statistics on the available facts are completely consistent with that. Don't prove it, but that concept of priming of the innate immune system, I believe, is one of the most powerful, important ones for long-term immunological health. So if there's been a defect to that these heat-killed mycobacterium products can give it a boost or reconstitute it. And that's why I think they're so important.
It's almost like a fountain of youth, isn't it? It's giving me potentially the immune system back I had when I was 18. It just sounds too incredible. And biologically, it makes sense because the way that you kill or attenuate these organisms is going to affect the architecture of the molecules, presumably, what we would call the epitopes. And if you have a particular preparation process that preserves the molecular integrity of the epitopes, they're still going to be as biologically active. So, to me, it makes perfect sense and supported by the empiricism that you're talking about. Presumably, the authorities in the UK are clamoring at your feet to authorise this vaccine so that I can get it, are they?
I wish they were. I wish they were. I mean, we've tried to get them to prove it for pancreatic cancer in 2016, and I mean the data was incredible. They want a bigger study, but you only do bigger studies when there is doubt. There was no doubt. This is highly statistically significant, and you only do it to establish the benefit-risk safety ratio. Now, this agent has been given to thousands of people in TB studies, and I've given it to hundreds of people with cancer. There's never been an SAE, serious adverse event, 3 or 4, ever recorded. This didn't seem to bother them with the COVID vaccines, where they were completely ignored all safety issues. So now you know the frustration we have that there's something really useful.
Yeah, Gus.
Yeah.
They had a 2-month trial with the COVID vaccine.
Yeah. Well, I won't go into the details where, when it was obvious there were some nasty side effects, it was decided to unblind it. And so, on the grounds of ethics...
And then freeze the results for 70 years.
75 years.
75 years.
But they tried to unblind it so that the people who were on the placebo could also get the vaccine, because it's unethical for them not to. Actually, I believe it was so that the side effect profile would be comparable to both. And I really do believe that, looking at all the raw data.
Yeah, unblinding the trial just completely removed any comparison because both groups became the same. Both groups had the active treatment. It was just outrageous thing to do. And I mean, it sounds to me like there's a simple treatment. It's just a few injections. It's not really a vaccine. It's just these attenuated or dead organisms.
I love that.
Sorry.
I just love the fact that you cottoned on and said it's not really a vaccine, it's an immune modulator, immune restorer. It's not a vaccine against any one thing. So I'm so grateful you made that, because it's so important for people to understand. There's a big difference between an immune restore the immune system. A vaccine basically wants a single response against a single antigen or a single bug-like flu. And we don't want to get this a bad name by calling it a vaccine.
Yeah. So it's absolutely not a vaccine. It's a bacterial stimulation that is restoring my immune system to what it was when I was young, and it's acting against viruses, bacteria, cancers, all these things, and I'm not allowed it. And I just find that completely outrageous, because if the Medicines and Healthcare Products Regulatory Authority, which I seem to recall is 86% funded by industry, if that allowed it, then you could prescribe that to me compassionately, because it would be a registered drug and preparation, and we would be allowed to use it. It's just outrageous.
I agree with you.
Now, it's interesting. What I'm trying to do, my group over the years, is to also stimulate T cells, but to make them move to where they're needed. And we use inactivated bacteria to do this, just as Gus does. But we've found that if you heat kill them, they're not nearly as good as if you use formalin. Now, what formalin does is it rings them together so we have little aggregates, and you can do special electron microscope pictures and you see all these little clumps of, and they're taken up by the factory that's going to make the T cells that we want in the wall of the gut, little tiny lymphoid aggregates that are called Peyer's patches. Now, if you have heat killed, they don't get taken up so well. So it's quite interesting when you're looking at a slightly different outcome. You have to really do the science and the research to work out the best way for that particular outcome. And what we've found is that 25% of people don't really deliver the T cells to the lung where they're needed very efficiently. And by stimulating the production of them in the factory, which is these Peyer's patches, little tiny lumps of lymphoid tissue in the wall of the small bowel, then we treat them with formalin to kill them, and by killing them with the formalin we aggregate, and they're taken up much more efficiently into the Peyer's patch. So we're both aiming to get T cells activated where we want them, but we use different ways of doing it.
Yes, there's similarities and differences there, because the heat kill mycobacteria still have to be processed and presented with a butyrate, actually, without which it won't do anything. So it's not that simple. So basically, in a way, we're doing the same things, starting from different places but converging on a very similar outcome.
I wonder if we could move on to something I want to hear Gus talk about, because we've got him here in Sydney. Gus, to me, has been the light in a very murky tunnel, identifying which other people don't. Well, they're now catching on to it, and it's going on everywhere. But Gus, would you like to just tell me, and John probably knows a lot about this, what your current thoughts are about post-vaccine, COVID vaccine and cancer development, because it's such an incredible...
People are talking about turbo cancers, and there's quite a lot of anxiety about this at the moment, it has to be said.
What's your thoughts at the moment?
Well, I first highlighted the fact that in my clinic I saw these melanoma patients, stable for years, suddenly relapse. Some of them are mild, but some of them really quite viciously. And they had I couldn't get anything, good explanation out of them, other than they'd all had a COVID vaccine booster, which I said is completely...
It was the booster.
The booster. They no problem with the first and second. It was the booster. And the booster is completely unnecessary. I mean, basically in vaccinology, if you need a booster, there's a great reason to be very cynical that the vaccine doesn't work.
Exactly.
But the second thing is the people who said we needed a booster, I think, were collective morons who understood no immunology, because their rationale was the antibody titers were falling. They're always going to fall. If they were not falling, you've probably got a multiple myeloma with a clone producing it, because it won't fall.
And the blood would become slush with all the antigenic challenge we've had over our entire lifetimes.
But they were falling because the suppressor cells were getting more boosted by the vaccine.
Yeah.
And so you're turning off the immunity. And the British data showed this first, I think it was week 21 or something in 2021 or 22. And it showed that after the booster, if you just watch for 2 months, the antibody levels went down, not just of the spike protein that was in the vaccine, but also the nuclear capsid, which is other parts of the virus. So you were getting this bystander immune depression. And I wonder how much that was related, because you only got it after the third one.
Yes. And, I mean, there was a very good paper showing that the T-cell response was completely eliminated.
That's right.
In 20% of cancer patients after the booster. They called it, and very accurately, T-cell exhaustion.
Yeah.
Basically, what are they flogging me to do this for? I've had enough. I've done my job. They just flogged them to death. And my big issue about this was a very dynamic, multi-changing variant virus. By the time you'd got even the first vaccine out there, it was of very little use, because the virus had changed and disappeared. And one of the papers I wrote with my colleagues right at the beginning of this is look at the history of coronaviruses. No vaccines ever work. The reason being is by the time you get a vaccine to induce a good enough immune response to it, the virus is mutated. And
the next one, yeah.
this is actually anti-helpful. It's not even helpful that the next one will be similar, so therefore it's partially primed. No, it locks the immune response into a totally focused called antigenic sin. That the body is never going to see a minor variant of that. It will just make the same again. So it will...
and the bus is gone.
The bus is gone. The bus is way gone. And so you've induced a sort of chaos in the immune system, fighting things that are not there. And therefore they're not fighting things that were there, that are there, that they were doing very well under control. So that was the first thing. The second thing that we had, and some very good papers came out, showing that the IgG subtypes, they went from 1 and 3 after the booster to 4. Now 1 and 3 are antibodies attack viruses, kill things. 4 is what you want to induce if you've had a transplant. So you tolerize the immune system, say, by the way, we've got a new chap here, don't eject him. So switch off and just, learn to live with him.
Which is exactly what happens when an allergist comes along and gives for the pollen, the respiratory tract looks at the pollen the same way it does a virus.
Yes.
And you say you inject 3 or 4 or 5 times, and up goes the IgG4, and down goes the response to the pollen.
Yeah. It's fascinating we got us together because these are wonderful complementary analogies. I mean, it really is unbelievable.
Well, let me ask you, what happens when you desensitize someone? Does that change cancer in people with cancers? If you're immunising people against the ryegrass pollens and you're getting the IgG4 going up and you're turning off the immune response to allergens, does that affect the cancer? Has anyone ever looked at that?
Nobody's ever looked at that, and I'm unaware of it. But
I bet it does.
It may well do, but it's obviously not a big enough issue the way we've found with
But
the
they're
COVID
doing it in
boosters.
much, much younger people.
They do it in much younger people. Well, we don't know about that, whether
Kids,
they come...
yeah.
And the irony here is if you allow natural immunity, say to a COVID virus or any other virus, but if you allow natural immunity to a COVID virus, you're going to get a polyclonal response. You're going to get, I don't know, maybe 20, 25 components of the COVID virus that the immune system recognizes. Therefore, when the virus does change and mutate, there'll be some of the components from the old virus that are still there, because you're looking at many different epitopes, whereas the vaccine is only looking at 1 or 2 epitopes. It just seems even obvious from a basic biological point of view again.
Absolutely. There are papers out there now which have been allowed to be published, like it was suppressed by this whole madness.
They pay the $10,000?
Yeah, they basically show that the innate immune response, i.e. of people who've been exposed to the virus, that immune response is far better than any vaccination, and that it can be just a T-cell response. And I'm one of these people. I have got a superb response against R2. I've never been vaccinated, and I've never had an antibody. No antibodies whatsoever. And there's lovely papers showing that actually when you looked early on in the pandemic, there were lots of people who had T-cell responses to it. They'd clearly seen it, flashed it off, they didn't even know they had it. Now, those people, if they did get infected, and it's important to point out that these people had no antibodies, just the T-cell response. But if they did get infected, there's another group of researchers that published papers showing that these people, when they did get infected, they had rapid T-cell response and fantastic IgG specific responses against the vaccine, and they were very unlikely to progress and get ill. And so, whereas the vaccine basically focuses on just specific bits, and because it was the spike protein, they missed the nuclear protein, which certainly in our work with HIV, that was important because it's totally constant. If you target that, it's the same in all the viruses. The spike and the envelope constantly change because that's what they're there for. They're basically decoys. They're shields. So the immune system attack them, and then they changed their number plate, as it were, in the getaway car. So they escaped the police looking for a certain number plate. And it's a very interesting analogy, which I think is very useful.
Just seems totally bizarre that they picked the part of the virus that changes most frequently to make the vaccine against. I mean, it just makes...
When I pointed out that this was madness, and that we'd already shown with HIV 4 epitopes have been far better than 3,000 epitope in the vaccines, which Fauci and everybody had pushed, which didn't work. The 4 epitopes are the best in the data. They just need a little bit further work, and you've got a fantastic vaccine. Nobody was interested in that, but we said the same thing for COVID. The COVID has the core epitopes are shared amongst all of them, and if they mutate, there's no virus. They're absolutely vital to the core.
Really good point.
So you target the Achilles heel. You don't bother shooting guns all over the place and hoping you get some. Go for the Achilles heel.
For someone who really doesn't understand the biology, it's so simple. They see the virus like one of these explosive things you put in the ocean with little spikes out of it, waiting for the ship to come along.
Yeah, mine.
Yeah, the mine.
Oh, the sea mines, yeah.
Mines. And it's the actions in the inside. And if you change things there, then it doesn't work. No, it's very, very good.
It really is. It really is quite bizarre that all these really, you would imagine, clever people make such a fundamental mistake. It seems incredible. Because how much of the fact that basically you didn't get antibodies to the virus, that means you'd fought it off with a minimal response, really. How much of that do you think is the fact that you nobly experimented on yourself with your bacterial stimulation in the past? Do you think that's boosted your immune system?
Oh, without doubt, very much so. And the vitamin D, because don't forget vitamin D, because it's the one thing that everybody can do without getting their doctor or their government to approve. And it is unbelievable.
Until they get onto it, and then it'll be banned.
Well, they tried to or whatever they call vitamin D. They actively tried to stop people thinking it might be useful in COVID.
Matt Hancock did it in Parliament, didn't he? Stood up and said vitamin. Yes, just.
Well, he was obviously. I mean, the best thing that can be said about Matt Hancock is I hope he doesn't survive anything ever again. He was the most malignant politician and the worst person in the world to be in that job at that time. But he was appointed by Boris Johnson. He was Prime Minister. He has to own this mess.
Quite incredible. So it really is. If this microbacterial stimulation becomes available, and I know you inject it, I would certainly be well and truly up for that, because it's going to give me less infections. It's going to give me less bacterial infections. It's going to reduce my chances of cancer. And yet I'm not allowed it. I just find that completely outrageous. And again, with Robert's preparation, the formalin preparation doesn't really surprise me, because, of course, the difference is that Robert's preparation is going through the gastrointestinal tract. So it's not at all surprising that there would be differences in the preparation. But I would be well up for that as well, because why not promote your mucosal immunity?
Yeah. Well, let me just tell you that I was surprised to see that Mycobacterium vaccae has been used in a TB trial where it was given orally, because John Stanford was convinced that it didn't need to be injected, it could be given orally because of the pair patches, exactly the same thing you're talking about. And, there are quite a few preparations out there that have Mycobacterium vaccae in oral preparation.
Don't they still in Brazil give oral BCG to young babies?
I believe they do.
And it's got good evidence that prevents meningitis and miliary TB.
Yes. Yeah. So for prevention and stimulation, the oral route is very good. I feel that remember my work's been on people who have broken down because they physically got cancer in front of me, and that's what I do. So getting injected, and here's very important, because just the difference between vaccine and an immune stimulator, immune modulator, it is very important. It has to be given intradermally, where you form a bleb, and that means that you then get myeloid-derived dendritic cells activated, going back and forth to the lymph node. If you give it subcutaneously, it does not have any benefit whatsoever. Or if it is, it's mild and it's delayed to it's too late.
Is that because it's disseminated too widely?
Yes, I think so. And I can assure you, a randomised trial has been done on this without any ethical input. It's being done by nurses who, in spite of training, still don't know the difference between intradermal and subcutaneous. And they've complained that this person hasn't had the mark, which you can tell 3 weeks later. If you give it intradermally, you know, because it has the mark, the erythema and the thing. And then I watched someone who said that this patient is allergic. They don't make any reaction at all. I said, let's see how you do it. They put it in subcutaneously on the ground. They had no concept of intradermal injection.
No. I mean, basically, we don't give it. There's no preparations we give intradermally. It's all either intravenous, intramuscular, or subcutaneous. There are no
knowledge with rats and mice. If you're giving adjuvants and things, you give it intradermally.
Exactly. Yeah.
I hadn't appreciated that. So it's an intradermal injection. So it's very, very superficial. Preparation. Now, obviously, we could talk for days, but there is one thing I'd like to get both your views on, really. During the recent few years, some products have been promoted, some products have been denigrated, and one that's perhaps been denigrated and attacked blatantly more than most is ivermectin. Just a little bit about your views on ivermectin. Are you finding it useful, Robert, at the moment?
Actually, I think hydroxychloroquine, which came out earlier, was beaten around far more. Anything that put its head up and looked as though it was working at the time was going to get beaten, because the whole scenario for the magic vaccine that was coming required there to be no alternate treatments. And so the shameful thing that existed at the time, first with hydroxychloroquine, then ivermectin, both of which are highly effective treatments, they were banned. In this country, Gus, you wouldn't believe it, in Queensland, where I'm going with a bulletproof vest on the weekend to visit my son, in Queensland, if you prescribed hydroxychloroquine for COVID, a drug which you and I have used hundreds of thousands of times, you could be jailed, not just kicked out of medical profession, but jailed. The answer to your question on ivermectin is that a breakthrough occurred literally in the last few months when David Scheim in the States put together a lot of really exciting good science and answered a question that people had thrown up against ivermectin. Well, you know, it acts very late. All these studies are on the assemblage of virus and whatever. And what David showed was, following a study that I had a little bit to do with, there were 3 studies showing that if you give ivermectin, the low oxygen saturation, which was present in people with mild to moderate disease, would go back to normal in 24 hours. It made no sense at all. To cut a long story very short, what ivermectin was doing was blocking the effect of the spike protein on the virus, agglutinating, bringing the red cells together, clogging them up in the small vessels in the lung so that the oxygen couldn't get saturating the hemoglobin in the red cell. So ivermectin had this dramatic effect. Now, the overwhelming data on something over 100 studies now on ivermectin show it is highly effective at reducing the intensity of disease, reducing admission to hospital, reducing death, and also reducing transmission of infection. There's a 30% less long COVID following people who are treated with ivermectin. So the database is overwhelming, although that sadly is so irrelevant. I talk to doctors all the time, and I talk to people who I know, who we have a mutual respect for our medical skill sets. They don't even want to discuss the possibility that hydroxychloroquine, which has got a very bad name in this country, and ivermectin, which has got an equally bad name, can possibly have an effect when we're paying over $1,000 a course for 2 antiviral drugs that don't work.
And they're very toxic.
And they're toxic.
They're far too toxic
They
to be
create
approved.
mutations which can transmit.
Yeah, they cause the mutations and make the whole pandemic worse. Yeah.
I rest my case.
Well, yeah, absolutely. Who was that, Robert? David who? Chime?
Shime, yes.
Chime. How do you spell it?
Scheim. David wants to talk to you, so
yeah, definitely.
The both of you.
Yeah. Just before we finish, we're we've got 55 minutes now. Time goes so quick. You hear a lot about ivermectin and cancer. Is it all hot air, or is there some potential trials that could be done here?
First of all, I want to totally agree with Robert that the ivermectin, the hydroxychloroquine has been used immunologically for years anyway, but the ivermectin is really an incredible drug, and it was obvious that this was useful. My personal things, I had people I knew who were really, really ill, and I was asked, should we try some ivermectin? And I said, absolutely, if they've got nothing else, try it. And I had a couple of cases where they were better within 48 hours after having unbelievable inflammation. Now, it was working, and we cannot go on here without mentioning Pierre Curie. I mean, he absolutely defended it. He basically undeclared war on ivermectin, and that undeclared war on ivermectin was orchestrated and conducted by, that's the book,
That's it.
by Anthony Fauci, who denigrated it. He called it horse dewormer, you mustn't take it, it's things. It worked. Now, why did he do that? Because he was clearing the ground for the vaccines. I believe this is a crime against humanity, what he did. This is a very simple drug, no side effects, it was curing. And we knew that because in the sways of the subcontinent, where millions of people take ivermectin to clear their flukes, let's not forget, this drug was given a Nobel Prize. It's so good for flukes and things like that because it prevents millions of people from getting blind. So it's like vitamin D. It's got a zero toxicity and a fantastic pass, but it was degenerated. Fauci wanted it to have a negative study at a dose that was so toxic in patients who were pre-funeral in order to decry it, when doctor after doctor who did use it was finding it fantastic. And like you're saying, health authorities decrying. I gave people ivermectin when they needed it, and I was just horrified what they had to pay for it because the government wouldn't do it. Yet this is a drug you can get for $1 a course in India.
Well, I can tell you now, there's some very interesting data which shows that to save a life with ivermectin costs $25. This is US dollars. To save a life with Paxlovid or Molnupiravir, the specific antivirals, I think it's a couple of $100,000.
Yeah.
And then I think they're cheating. Because I think it saves too many lives. But it's in Australia now, it is quite legal to prescribe ivermectin, even though it's not supported with any support from the government. But you can now get the formulating chemists in Australia will make it for 60 cents for a 12 milligram capsule.
Yeah, that is fantastic.
Which is
news.
fantastic news.
60 Australian cents.
Yeah,
60 is, and they're nothing.
yeah, that's
30 English pence.
Gus is going to stay here in Australia because it's so cheap.
yeah.
Oh yeah, if only.
I want to answer the other part of your question, which
Please. I'll just say I interviewed Pierre Curie in 2020 and the video was banned.
Really?
Yeah. Oh, this is overwhelming global fascism on a scale. It all tremor our shoes about. This is fascism which has spread out of control, and we must do what we can to stop this ever happening again. Going back to the ivermectin cancer, when I've looked at this very carefully, so it's something, if Fauci says to me it's bad and it's dangerous, I go and do the research. And I find, as usual, it's completely the opposite. I mean, Fauci should have been defenestrated and knocked off his position decades ago. And Rand Paul agrees with me. He wants him in jail for denying to Congress crimes against humanity, and I totally agree. But going back to ivermectin, we started looking at it. And, you know, I did a lot of work in thalidomide doing the analogues, and we developed lenalidomide, pomalidomide, which are now multi-billion-dollar sellers in the world. And we looked at the mechanisms. When we found the mechanisms for cancer, it had nothing to do with how people thought it worked. So when I look at the mechanisms for ivermectin, yes, they do hit some very interesting anti-cancer pathways. So ivermectin is a potential anti-cancer agent, but it will not get any boost from Big Pharma, who are only interested in agents they can charge hundreds of thousands a year of, like the checkpoint. Ivermectin is, I believe, and we're working on it in the laboratory, so I put my money where my mouth is. We got no funding to do this, but on the other thing, we're putting it in parallel with other things to look at the real, and I'm very, very optimistic we will find something, because ivermectin, and then there's mebendazole and febendazole, which are the same drug. One is cheap and give to animals, the other's dear and you give to humans, which is the main one. But they all have action on the mitochondria, which is the Achilles heel of a cancer cell. So I think, you know, out of this, we might have something really much more effective in cancer in the future that doesn't involve Big Pharma and the billions they claim to the government. They have to charge a fortune because of the billions of research they spend. Bullshit. They don't spend it, but they just buy it up and sell it cheap. The big billions in research that's done is usually done by the charities and the government. So I think it's about time we challenge this hegemony about Big Pharma doing this, and they've completely controlled what's done and what's allowed to be done by raising the barriers of entry for everything, for small spin-outs, for academic work, for repurposing. And I think it's about time we stood up to that and said, as Churchill would say, up with this we will not put. You know, give us something to do this.
Absolutely. And the mitochondrial effect, Robert, could be part of the effect that you're seeing in your chronic patients as well. The crossover between vaccine injury, long COVID and chronic fatigue.
We've talked about the post-vaccine or the post-viral infection syndrome, the long COVIDs. What I find fascinating, and I'm sure you're going to find this fascinating when they start looking at those who do well or not particularly well with your product, is this computational type of genetics where they're actually looking at genetic interplay. So we've gone past the Mendelian, we've gone past the point mutations. We're now looking at the way this gene interacts with another. And with these people who are going on and getting long-term problems, one, they get a persistent antigen and they've got defects, particularly in innate immunity. But the genetic defect, the second cluster, is in mitochondrial development of high-energy phosphate bonds. It's really very...
Which is why ivermectin may be very useful.
Which would be fascinating,
Excellent, gentlemen. Thank you both so much. The fact that that you have both got such distinguished medical careers in different countries, although, of course, Gus has worked in Australia. Yeah. And he had the good sense to marry an Australian as well, you mentioned yesterday. Oh, well, I didn't know that.
I got an Australian passport.
Yeah.
Oh, wow, so you can join the shortest queue in the airport. Yeah. No, the fact that you've come from different angles at this and have come to this agreement, to me, means that is really powerful supporting evidence that the conclusions are the same from different academic areas of medicine. It's I'm totally convinced, and I'm sure many people watching the video will, and can't wait for the next conversation. But for now, thank you both very much.
Thanks very much.
It's
great having you with Robert here. Yeah. It's
fantastic. It's been brilliant.
Up an Australian map, John.
Yeah.
So I apologise. I didn't get round to it.
Oh, the British viewers will appreciate the map moment. Yeah. We'll have to make a map video next time. Next time I'm there. It's lots of interesting stuff. But for now, thank you very much.